Thank you, all of you, for coming to the seminar. So this seminar is jointly hosted by the Global Obesity Prevention Center at Johns Hopkins and the Center for Early Life Origin of Diseases, also based at Johns Hopkins School of Public Health. So today we're very fortunate to have Frank Hu, who's a professor in nutrition epidemiology from the Harvard T.H. Chan School of Public Health and a professor of medicine at the Harvard Medical School. So incidentally, I'm frequently asked to comment on, frequently asked by the press to comment on studies that come out that are gaining a lot of attention by the general press. And often those studies are Frank's studies because they're quite influential. And I remember one day I was asked by the press to make a comment on a paper that came out of Frank's. And then later that day, we heard that Frank would be in Baltimore and he could potentially come and give a seminar. So it was quite fortuitous that we were able to organize this so that he could come and give us a talk. For those of you in the nutrition field, you all know that Frank is very prominent. He's done groundbreaking work. His titles include, he's the director of the Boston Obesity Nutrition Research Center in Epidemiology and Genetics. He's also written a seminal textbook in obesity epidemiology. Again, his name in many ways is synonymous with the field of nutrition. So without further ado, we'd like to invite Frank to give us a talk. And again, thank you for joining us.
Thank you, Bruce, for your kind introduction and the invitation. It's really a great pleasure for me to be here. I'm particularly happy to be here because we have quite a few Boston representatives here, and we have brought some snow from Boston to Baltimore, so I hope you don't mind. And I'm also happy that my daughter, Emily, who is in the audience, Emily is a junior at Hopkins, majoring in public health. So, of course, always happy to see Emily, especially at Hopkins. So, my talk is going to be very broad. I'm going to talk about prevention of global obesity and diabetes epidemics, the intersection of science, politics, and policies. I must admit that I know something about science, but not too much about politics or policies, but I will try my best. There is no question that we are in the midst of global obesity and diabetes epidemics in the US. As you know, 2/3 of Americans are overweight or obese, and almost 10% American adults have diabetes. However, the obesity and type 2 diabetes epidemics are not confined to the US. It's actually very global. For example, in China, the prevalence of type 2 diabetes has increased dramatically in the past several decades in parallel with economical development and unprecedented pace of urbanization. So right now, almost 10% Chinese adults have diabetes, and this translates into 100 million people with diabetes, 100 million people with diabetes in China. This is a huge number, and you can imagine that what kind of impact this obesity and diabetes epidemics will have on the Chinese healthcare system and also on the economy. Compared to Caucasians, Asians, including Chinese, tend to develop diabetes at much younger age and at much lower BMI levels. There are several potential mechanisms for increased susceptibility to diabetes in Asian populations. First, this phenomenon called normal weight metabolically obese is very common in Asian populations. So many people who have normal BMI, but they have a relatively high amount of body fat, especially abdominal obesity or visceral adiposity. And another potential reason is increased genetic susceptibility. This is commonly referred to as the thrifty genotype hypothesis. So people who carry those genotypes are more likely to develop metabolic diseases, especially in the very abundant environment. However, recent genetic studies have not provided strong support for this thrifty genotype hypothesis. I will come back to this in just 1 minute. Another potential reason is exposure to undernutrition or malnutrition in utero or early life, which may contribute to increased susceptibility to metabolic diseases in later life. This is commonly referred to as the thrifty phenotype hypothesis. I will present some data from a Chinese population on the effects of in utero exposure to famine and risk of type 2 diabetes in adulthood. Finally, there may be interactions between genetic susceptibility and rapid changes in diet and lifestyle that have been caused by the epidemiologic transition and nutrition transition in developing countries. And this kind of interactions may put people at accelerated trajectory of developing type 2 diabetes. In the past several years, genome-wide association studies, or GWAS, have identified numerous common genetic variants for obesity and type 2 diabetes in both Caucasian populations and Asian populations. However, most of the genes have modest effects on obesity or type 2 diabetes, and those genes are not very useful clinically in terms of predicting future risk of obesity and type 2 diabetes beyond the traditional risk factors. And also, those genes are not sufficient in explaining ethnic differences in susceptibility to diabetes and other metabolic diseases. So again, the results from recent GWAS studies do not provide strong evidence to support the so-called thrifty gene hypothesis. On the other hand, there is increasing evidence to support the thrifty phenotype hypothesis or the Barker hypothesis. And according to this hypothesis, exposure to poor nutrition in utero or early life increase susceptibility to chronic diseases in adulthood. So to test this hypothesis, we analyzed the China Nutrition and Health Survey data, which is a national representative sample in China. And this figure shows the prevalence of hyperglycemia and type 2 diabetes by birth year. As you can see that older people tend to have higher prevalence of hyperglycemia or type 2 diabetes. But as you can see here, there is a big jump in the prevalence of diabetes among people who were born between 1959 and 1961. So this is the peak of the so-called Great China Famine period, or the Great Leap Forward period. So during that period, there was widespread famine in China, especially in rural areas. So millions of people died during that famine period. And so people who were conceived or born during that period had significantly elevated risk of developing type 2 diabetes in adulthood. So this very crude data provide support to the Barker hypothesis or the fetal origin hypothesis. When we look at the data in more detail, so we analyze the prevalence of hyperglycemia or type 2 diabetes according to various birth cohorts and also adult dietary patterns. As you can see that the the birth cohort who were exposed to famine in utero or in early life had significantly elevated risk of developing type 2 diabetes. However, this elevated risk was mainly confined to people who followed affluent or Western dietary pattern in adult life. So for those who followed a more traditional dietary pattern, early life exposure to famine did not appear to increase risk of developing diabetes in adulthood. So these results suggest an interaction between early life exposure and adult dietary pattern. So from this study, we concluded that exposure to severe famine in fetal life increased the risk of hyperglycemia and type 2 diabetes in adulthood. And this association appears to be exacerbated by a nutritionally rich environment in later life. So this is consistent with the Barker hypothesis or the fetal orange hypothesis. And this data suggests the interaction between in utero and adult life exposures, and this mechanism is perhaps through epigenetic changes. But of course, this is hypothesis need to be tested in animal studies or molecular biology studies. So in the past several decades, the dietary patterns in Chinese population have changed dramatically. As you can see that consumption of animal food has increased considerably, and especially meat intake. As you can see that meat intake has increased several-fold in the past several decades. So these changes in dietary patterns have led to increased consumption of animal foods and decreased consumption of minimally processed plant foods, and also increased consumption of saturated fat. So most of the saturated fat come from animal products. We know that saturated fat intake increase total and LDL cholesterol, which is a major risk factor for cardiovascular disease. On the other hand, monounsaturated fat and polyunsaturated fat from plant sources decrease total and LDL cholesterol and have been shown to reduce risk of cardiovascular disease. So long-standing dietary recommendation has been to replace saturated fat with unsaturated fats from vegetable oils, such as olive oil, canola oil, and also nuts and fish to reduce the risk of cardiovascular disease. However, this recommendation has been challenged by a meta-analysis published last year in Annals Internal Medicine. So this meta-analysis looked at the relationship between various dietary fatty acids, including saturated fat, and the risk of cardiovascular disease. And the authors concluded that there is no significant relationship between higher saturated fat intake and risk of CHD. And in their paper, they stated that current evidence does not clearly support cardiovascular guidelines that encourage higher consumption of polyunsaturated fats and a lower consumption of total saturated fats. You might have seen some sensational headlines following the publication of this meta-analysis. Mark Bittman, who is a celebrity chef and was a columnist in New York Times, wrote an op-ed entitled "Butter is Back." And the Time magazine published a cover story, "Eat Butter." And then our school magazine published a big story entitled "Is Butter Really Back?" So beyond those headlines, what is the real story? So we look at the meta-analysis very, very carefully, And apparently, there were many errors in terms of data extraction and data analysis. And also, there is a serious misinterpretation of the data. One of the major problems of this meta-analysis is that it looked at saturated fat in isolation. But we know that in real life, when we increase or decrease saturated fat intake, we have to change the other components of the diet, right? So as you can see that the major sources of calories in the US diets are different type of fats, carbohydrates, and protein. So typically when people decrease their saturated fat intake, they increase their carbohydrate intake, and mostly refined carbohydrates and added sugar. So we are basically comparing a diet high in saturated fat and with a diet high in refined carbohydrates and added sugar. So it's not surprising that you wouldn't be able to find association between saturated fat intake and risk of CHD, because both diets are bad diets, right? So you compare one bad diet with another bad diet. On the other hand, if you compare a diet high in saturated fat with a diet high in healthy fats, those unsaturated fats from vegetable oils and nuts, seeds, and avocados and fish, then you will see that this kind of diet is much better than a diet high in saturated fat. So I think the bottom line is that when we talk about the effects of saturated fat, we really have to look at what is the replacement macronutrient, what is the comparator. And if you compare saturated fat with unhealthy carbohydrates, they are equally bad. But if you compare saturated fat with healthy fats or healthy carbohydrates, and then saturated fat, of course, is not a healthy option. So I think that's a very important way to interpret the saturated fat data in a more, I guess, scientifically sound way. Dietary sugars have received a lot of attention recently. We get natural sugars in fruits and vegetables, and milk. But most of the sugars in our diet come from added sugars in beverages and processed foods. On average, Americans consume almost 22 teaspoons of added sugar per day. We're talking about added sugar. So those are the sugars added to the beverages and the processed foods. And half of those added sugars come from sugar-sweetened beverages. There has been long-standing debate about the role of sugar in the development of obesity. And the data were not very consistent, especially in earlier studies. However, a turning point in this debate occurred in October 2012, when New England Journal of Medicine published 3 original papers on sugar-sweetened beverages and obesity. So the first paper was led by Lucci in our group, looking at the interactions between consumption of sugar-sweetened beverages and the genetic risk factors in relation to obesity. And then 2 other papers were randomized clinical trials looking at the effects of reducing SSB consumption and prevention of childhood obesity. So in our study, we calculated a genetic risk score based on 32 obesity genes identified in GWAS. As you can see that this is 21st century David. His abdominal obesity, I can tell you, is not caused by those genes, but caused by the toxic food environment. Anyway, so a genetic risk score was based on 32 common genetic variants identified from GWAS. So the more genetic variants you carry, the higher risk of becoming obese. This figure shows the interaction between consumption of SSB and the genetic risk score in relation to BMI. So the y-axis is BMI levels for each additional 10 risk allele increment. And we have 3 cohort studies with GWAS data, the nurses' health study, health professional follow-up study, and the genome, woman genome health study. As you can see that as the consumption of SSB increase, the genetic score associated BMI also increase in a dose response manner. So on average, each 10 risk allele is associated with about 1.5 unit increase in BMI. However, for people who consume SSBs on a regular basis, at least 1 serving per day, the 10 risk allele associated with more than 2 unit increase in BMI. And there is a significant interaction between SSB consumption and the genetic risk score, and the interaction was highly consistent across the 3 cohorts. So this analysis suggests that SSB consumption actually amplified the genetic risk of obesity. So the main conclusion from this study is that regular consumption of SSB and high genetic susceptibility may exaggerate the effects of each other on body weight and obesity risk. And the implication is that the genetic effects of obesity can be offset by healthy beverage choices. So this is actually a positive message. So if you follow a healthy diet and a lifestyle, the genetic effects of obesity may be mitigated. So I think this is a very positive message in terms of public health interventions. This is a randomized clinical trial conducted in the Netherlands. This is actually a placebo-controlled, double-blinded trial. In this trial, 640 normal weight school kids were randomized to 2 groups, a sugar-sweetened beverage group and a sugar-free beverage group. And the unique feature of this study is that the investigators and most of the kids couldn't tell which group they were assigned to because the soda can look exactly the same between the sugar group and the sugar-free group. So this is a very unique feature of a dietary intervention study. And after 1.5 year intervention, there is a significant reduction in BMI Z-score in the sugar-free group. So this study has provided, I think, the strongest evidence so far that reducing sugar-sweetened beverage consumption is effective in preventing childhood obesity. In addition to obesity, there is also strong evidence that regular consumption of SSBs is associated with increased risk of type 2 diabetes. So this is a meta-analysis conducted by Vasant Malik in our group. This meta-analysis indicates that 1 serving per day of SSB is associated with about 26% increased risk of developing type 2 diabetes. And this association remained significant even after adjusting for BMI. So it suggests that the adverse effects of SSB consumption on type 2 diabetes are not entirely explained by body weight or obesity. So I think the current evidence on several major dietary factors, such as different types of fats and added sugar, various health outcomes, has become very solid. So the question is how to translate the evidence, the scientific evidence, into nutritional policies. So one of the processes of translating science into policies is through the development of dietary guidelines. So every 5 years, the USDA and HHS, Department of Human and Health Services, release dietary guidelines for Americans. So in the past 2.5 years, I have had the privilege to serve on the 2015 Dietary Guideline Advisory Committee, or the DGAC. So our task was to review the current science on nutrition and health and develop scientific report, the DGAC report, and which will serve as a guide for the government to develop the policy document, which is the 2015 Dietary Guidelines for Americans. So we just submitted the scientific report to the secretaries of USDA and the HHS. The report was published in the USDA website last week, and it has received a lot of comments. And for the next step, the USDA and HHS will develop the policy document, which is the 2015 Dietary Guidelines for Americans. And then those dietary guidelines will be implemented through various federal programs, such as the WIC program, school lunch program, SNAP program, and so on and so forth. So those dietary guidelines have huge impact on those programs, and also, of course, on people's eating behaviors, and on the production of food items and what kind of food you're going to buy in the supermarkets. So this committee includes 14 scientists from around the country, and this is a very diverse and multidisciplinary expert panel. The chair is Dr. Barbara Minen, and the vice chair is Alice Lincolnston. So in the past 2.5 years, we had 7 in-person public meetings, had numerous conference calls and webinars, and it has been a very intense and time-consuming process. As I just mentioned, our charge was to provide science-based recommendations to the federal government on how food, nutrition, and physical activity can promote the health of the U.S. population, help reduce the burden from major chronic diseases and other lifestyle-related health problems, and how best to accomplish those goals at individual and population levels. And the DGAC report will inform the development of the policy document, the dietary guidelines for Americans. This is our conceptual framework, which is based on the socio-ecological model. So this model recognizes the dynamic interplay between diet and physical activity patterns and behaviors. And those behaviors are influenced by multiple contextual factors, such as socio-economical factors, physical environment, food environment, public and private policies. And those behaviors, individual behaviors, together with the contextual factors, influence body weight, physical fitness and function, nutritional status, and a wide range of health outcomes across the lifespan. So the DGAC comprised 5 subcommittees. The SC1 was focused on food and nutrient intake and health, looking at current status and time trends. SC2 examined various dietary patterns and a wide range of health outcomes. The goal was to identify healthy dietary patterns that are associated with decreased risk of diabetes, obesity, cardiovascular disease, and cancer and other chronic diseases. SC3 examined the approaches to change diet, physical activity behaviors at the individual level. What kind of approaches are effective in changing individual behaviors? And SC4 evaluated strategies or approaches to improve the food and physical activity environments. And SC5 look at food safety and environmental sustainability. There were also 4 working groups focused on several cross-cutting topics of public health importance, including added sugars, sodium, saturated fat, and physical activity. I want to emphasize that the evidence-based review process was comprehensive, systematic, and also very up-to-date. We used the USDA now process for most of our systematic reviews. Now stands for Nutrition Evidence Library, and this is a very comprehensive and systematic approach to summarize and analyze the existing literature. This process involves several steps. So first, we identify topics and develop systematic review questions. So in our report, we identified more than 100 review questions for systematic reviews. And then we conduct literature search, screening, and selection of the studies, and then conduct data extraction and the risk of bias assessment, and then synthesize a huge amount of evidence, and then we develop conclusion statements and grading the evidence, and then finally we develop research recommendations and implications. So the DGAC recognized the public health crisis that the U.S. population is facing. So overall, more than 117 million U.S. adults suffer from preventable chronic diseases, including high blood pressure, CVD, diabetes, and various forms of cancer. 2/3 of U.S. adults and 1 in 3 children are overweight or obese, and more than half of the adults have 1 or more cardiometabolic risk factors. The DGAC also recognized a major gap in the overall dietary pattern in the U.S. population. The U.S. population has lower consumption fruits and vegetables, whole grains, high consumption of sodium, saturated fat, refined grains, and added sugar, and also empty calories. The U.S. population consume several key nutrients, including vitamin D, calcium, potassium, and dietary fiber. So what are the major takeaways in the 2015 DGAC report? So this is a quick summary, some of the new features or takeaways in the report. First of all, the report is focused on overall dietary patterns rather than individual nutrients. So this is actually a paradigm shift from previous DGAC report. And secondly, the upper limit on total fat was removed. So the previous DGAC recommends no more than 30% or 35% calories from total fat. And the current report removes the upper limit on total fat and put more emphasis on the type of fat. However, we retain 10% upper limit for saturated fat based on the current evidence. And a previous DGAC recommend no more than 300 milligram of dietary cholesterol per day. However, this recommendation is not carried forward in our report because there is very little evidence that high amount of dietary cholesterol has major appreciable effects on serum cholesterol or cardiovascular disease. So the implication is that moderate consumption of eggs, which are major sources of dietary cholesterol, can be included as a part of a healthy diet. And then for the first time, the DGAC considers environmental impact of food production and food consumption. And that's led to the recommendation to reduce red meat consumption for both health reasons and also for the environmental reason. And for the first time, the DGAC sets a 10% calorie upper limit on added sugar based on the current evidence that higher consumption of added sugar is associated with increased risk of obesity and diabetes. For sodium, the DGAC retains 2,300 milligram per day limit, but it doesn't carry forward the lower limit, which is 1,500 milligram per day, because there is no convincing evidence that reducing sodium consumption to a very low level is associated with improved cardiovascular outcomes. And also the current consumption, average consumption is about 3,500 milligram per day. So it's very difficult to reduce the consumption level to 1,500 milligram per day at the population level. And coffee consumption, regular coffee consumption is recommended as part of a healthy diet and lifestyle. And I think this has led to a lot of very aesthetic headlines in the newspaper. Now you can drink more coffee. And I'm coming back to this in just 1 minute. So this is a very interesting recommendation. We're not recommending people to drink coffee to reduce their risk of chronic diseases. What we are saying is that regular coffee consumption is not associated with increased risk of chronic disease, and it can be included as part of a healthy diet and lifestyle. And the report also indicate that farm-raised and wild-caught seafood are equally nutritious in terms of amount of omega-3 fatty acids. Finally, a key message in the report is that we should promote a culture of health rather than a culture of disease. And we should make healthy choices more accessible, affordable, and normative in our communities. So the overall dietary patterns that are recommended by the 2015 DGAC include several features. Those dietary patterns emphasize high amount of higher consumption of fruits and vegetables, whole grains, legumes, and nuts, and include low-fat dairy products and seafood, limit saturated fat and sodium, refined grains, and sugar-sweetened foods and beverages. And those patterns are lower in red and processed meats, and alcohol if consumed in moderation. And the good news is that individuals can combine foods in a variety of flexible ways to achieve healthy dietary patterns. And these strategies can be tailored to meet the individual's health needs, dietary preferences, and cultural traditions. So for dietary fat, in practice, long-hydrogenated vegetable oils that are high in unsaturated fats and relatively low in saturated fats, instead of animal fats or tropical oils, should be recommended as a primary source of culinary fat. We are not recommending a traditional low-fat, high-carbohydrate diets because in low-fat diets, fats are often replaced with refined carbohydrates, and this kind of diet can increase triglycerides and decrease HDL cholesterol. And therefore, the dietary advice should put the emphasis on optimizing the type of fats and not reducing total amount of fat. We also reviewed evidence on low-calorie sweeteners or artificial sweeteners, and we concluded that there is moderate evidence to support replacing SSBs with low-calorie sweeteners for reducing caloric intake, body weight, and adiposity in short-term studies. Most of the studies lasted for 6 months to 1 year. There is limited and inconsistent evidence of association between low-calorie sweeteners and long-term body weight control and the risk of type 2 diabetes. Because the evidence for low-calorie sweeteners is insufficient, those sweeteners should not be recommended for use as a primary replacement for added sugar in foods and beverages. So we recommend water as a primary replacement for SSBs, especially for children, because water is calorie-free, is accessible, and inexpensive. So in terms of coffee, we reviewed more than 50 meta-analysis and systematic reviews on coffee and a wide range of health outcomes, including type 2 diabetes, cardiovascular disease, various forms of cancer, and neurodegenerative diseases. Our main conclusion is that moderate coffee consumption, 3 to 5 cups per day, or up to 400 milligrams of caffeine, is not associated with increased long-term health risk among healthy individuals. And on the contrary, there is moderate amount of evidence showing potential health benefits associated with coffee consumption. In particular, coffee consumption has been consistently associated with lower risk of developing type 2 diabetes, cardiovascular disease, some cancers, and also lower risk of Parkinson's disease. However, there is a concern with the safety of high caffeine intake, such as which might occur with high consumption of large-sized energy drinks which contain a high amount of caffeine. And this concern is heightened when energy drinks are combined with alcoholic beverages, especially among vulnerable populations such as adolescents and the young adults. For aspartame, which is the most commonly used artificial sweetener, our conclusion is that at the level that the US population consumes aspartame, it appears to be safe. However, there's still some uncertainty about the long-term effects of aspartame, especially on some cancers. So this indicates a need for more research. As I mentioned earlier, a major message in the 2015 DGAC report is to create a culture of health. And there are several key components for creating a culture of health. First, the population health should be a national and a local priority. And then the healthy lifestyle resources should be made accessible, affordable, and normative. healthcare and public health professionals should take leadership roles in prevention, set new systems standards to promote health in patients, clients, and staff. Healthcare public health systems should shift their paradigms from disease treatments to a greater emphasis on prevention. Initiatives and incentives can be offered through public and private policies and various settings to emphasize personal health promotion, disease prevention, and weight management. And incentives should be used to encourage initiatives, environmental and policy changes, improve food beverage standards and products, and the preventive services. So one of the policy initiatives we recommend for consideration is the soda tax. Soda tax is a very controversial issue in the US. However, soda tax has been endorsed by several national and international organizations, including the American Academy of Pediatrics, American Medical Association, the IOM, the American Cancer Society, and now the 2015 DGAC report. And several studies have already shown that sufficient amount of soda tax can be effective in reducing purchase and consumption of sodas. However, politically, this is a very challenging issue. In New York City, as you know, several years ago, Mayor Bloomberg tried to put a limit on large portion size soda, but this proposal was struck down by the state Supreme Court, and the beverage industry portrayed Mayor Bloomberg as the nanny. I think, again, this is a very sensitive issue politically. However, just a few months ago, Berkeley passed the first soda tax in the US, but this proposal failed in San Francisco. And 2 years ago, Mexico successfully passed legislation placing 8% sales tax on sugary soft drinks to combat their obesity problem. I think this is very significant because obesity is now a global problem. In terms of soft drink consumption, even though in the US, soft drinks have declined in the past decade, the consumption of soft drinks has skyrocketed in other parts of the world, especially in developing countries. So I think it's very important to use all kinds of strategies, including soda tax, to discourage the purchase and the consumption of soft drinks in those populations which are undergoing rapid nutrition transitions. Last year, the FDA proposed several changes in the nutrition facts label. One of the proposed changes is to add a new line on the amount of added sugars in the food or beverage. And this will help the consumers to identify the amount of added sugar in the food, because right now, the nutrition facts label lists the total amount of sugar in the products, but you cannot tell how much sugar is added to the products. So the DGAC report recommends that the nutrition facts label include the amount of added sugar, not just in grams, but also in teaspoons, because most people wouldn't be able to tell how much added sugar by just looking at how many grams in the label. So hopefully the FDA will accept our recommendation and make the proposed changes. However, this proposal has met huge resistance from the food industry. I guess this is not surprising. One of the most controversial aspects of the 2015 DGAC report is the environmental impact. Again, this is the first time the DGAC considers the environmental sustainability as part of the scientific review and the recommendation. So based on the current evidence, the report concluded that a dietary pattern higher in plant-based foods such as fruits and vegetables, whole grains, legumes, nuts, and seeds, and lower in animal-based foods is more health-promoting, and it's also associated with lesser environmental impact than is the current average U.S. diet. So the implication is that the U.S. population should be encouraged to move towards the dietary pattern noted above while decreasing overall total calories. And this dietary pattern can be achieved through a variety of dietary patterns, including the healthy U.S. style pattern, the healthy vegetarian pattern, and the healthy Mediterranean style pattern. Each of these patterns provide more plant-based foods and a lower amount of meat than are currently consumed by the U.S. population. However, this environmental consideration doesn't sit very well with the Congress. Last year, in the massive spending bill, Congress inserted some language that discouraged our committee from talking about the environment in our report. So they basically told us not to consider environmental impact of food production and food consumption, but we included a whole chapter on, on environment anyway. We know that you cannot really separate the environment from the food, from the health, and from the agriculture system. So the food system, population health, and environmental sustainability, they are intertwined, and they cannot be isolated from each other. And predictably, the meat industry is very unhappy about the report, which recommends lower consumption of red meat and processed meat. Worldwide consumption of meat is increasing dramatically. It will continue to increase, so this will have enormous impact not only on human health, but also on the environment in terms of the greenhouse gas emission and land use, energy use, and water use. On the other hand, the report has received strong support from the public health community. Mary Nassau, the author of the Food Politics, wrote in her blog, the DGAC has produced an honest, straightforward, courageous report, thoroughly based on research, and at long last, without mincing words. So this is, of course, very positive and encouraging comment. And then remember Mark Bittman, who wrote the op-ed on Butter is Back. He also wrote a very extensive op-ed on the DGAC report in New York Times, How Should We Eat? This is a very interesting comment. He said, industry representatives hate the report, a good indicator of its value, and will fight to keep its recommendations from becoming policy. So as I mentioned earlier, our report will serve as a guidance for the development of policy document by the federal government. So it's possible some aspects of the report will not be translated into policies. So in his op-ed, he said, the smart environmental qualifications and much else will be fought furiously, but whatever is adopted will become official policy and will strongly affect school lunches and other federally funded meal serving programs. Overall, these recommendations deserve our report. So he urged his readers to go to the USDA website and provide comment on the report, because there is a 45-day public comment period in the USDA website. I guess I have recounted my own experience or journey in producing some of the science, and also my personal experience in translating the science into policies by involving in the Dietary Guideline Advisory Committee. So, of course, the journey is not smooth, and it has a lot of bumps and roadblocks, and it's not over yet. But one of the important lessons that I have learned is that the stronger the evidence, the better the policies, because the science is the foundation of policies. So our job is to produce the strongest evidence possible for the to lay the foundation for developing policies. So last week, after the DGAC report was published online, we actually held a symposium at Harvard School of Public Health. For those who are interested in watching the webcast, you can go to this website, and several committee members spoke, presented recommendations, and also the evidence-based review process. So thank you very much for your attention. No question, very clear. So.
Do you have a question? Do you want to use the microphone? Is that because we're taping, so.
Thanks for your talk. My question pertains to a remark you made in the middle, which is that these guidelines are very important and that they have a big impact. And I don't know a lot about that topic, but I'd like to know more. So what is the evidence that these guidelines matter? And where does it come from, and how strong is it?
Well, first of all, so all the federal programs I mentioned earlier, like the school lunch program, the WIC program, women and infant programs, the SNAP program, or the food stamp programs, they have to follow the guidelines in terms of the amount of saturated fat, for example, the amount of added sugar, and also the major food components. So clearly, I mean, those guidelines directly affect the type of meals in schools.
Well, the two don't follow. What you said is that it's a rule.
Right.
It doesn't constitute evidence that it has an effect.
Well, so by default, those programs have to follow those guidelines, and
But that doesn't mean they do. Is there any evidence that population surveillance detects the effects of these things?
Yeah, that's a good question. I mean, whether there is an evaluation, I'm not sure. But I think the federal programs, by default, they have to follow those guidelines. And also, those guidelines, of course, will have direct impact on for example, the nutrition facts labels I mentioned earlier. And well, the nutrition facts labels, based on the data from CDC, about 50 to 60% of people, look at those labels, or whether they actually, whether those labels will affect people's food choices, I think need to be evaluated. But at least, well, it has been done in relatively small studies, and does show that people who read those labels make better food choices. But again, I think those kind of studies need to be done in much larger scale. And also, as you said earlier, we need to look at how those guidelines will impact people's individual behaviors, and also those programs.
Hi, Frank. Thank you so much for the wonderful talk. It's very stimulating and also very encouraging. I haven't personally get a chance to read the report, but it sounds like it could be a landmark report towards a healthy diet recommendation. I just wonder, when you provide the guideline, do you have the age-specific recommendations? Children versus adult, within children has a different developmental stages, because their health, nutritional need varies, depends on their developmental stages.
Right, yeah, it's certainly a very, very good question. So the dietary guidelines for Americans are developed for the US population 2 years old, 2 years or older. So it basically applied to almost the entire US population. I know the USDA is trying to develop separate guidelines for infants, and because the nutritional needs are very different for infants and for young children and for adults. And in our evidence-based review, most of the literature, of course, is derived from studies on adults, and not many studies have looked at different dietary patterns in children, and the health outcomes, of course. The chronic diseases occur mostly in middle-aged adults or older adults. So I think the dietary patterns that we have identified, such as the healthy Mediterranean style pattern, the healthy vegetarian pattern, and also the healthy USDA pattern, those patterns most likely apply to children and young adults as well, even though the evidence is relatively limited at this point.
Thank you very much, Dr. Hu. One of the slides you mentioned that that the healthy choices for beverages to be replaced by the SSB. What comes to my mind immediately is fruit juices.
Mm-hmm.
And I recall one of your papers in the BMJ that the fruit juices could be associated with increased risk for diabetes. How do you see that interplay?
Right. Yeah, we didn't review the evidence on fruit juices because there are not that many studies on fruit juices and obesity and type 2 diabetes. So besides our study, there are only a handful of other studies looking at fruit juices. And also fruit juices are very heterogeneous. I mean, so you have 100% fruit juices versus other type of fruit juices. But I think for fruit juices, based on our data, their effects are not very different from fruit drinks or even sugar-sweetened beverages, because those are liquid calories. So the recommendation by the American Pediatric Academy is that for children, no more than 6 ounces of fruit juices per day. So moderate consumption, I think, is okay, but high amount of consumption is not recommended. What's that?
Water would be the healthy replacement.
Yeah, I think like SSBs, water would be the optimal replacement for juices or fruit drinks. Mm-hmm.
Thank you very much for your talk. I was excited to hear this paradigm shift from talking about particular nutrients to talking about broader changes. Could you talk a little bit more about what you imagine when you're talking about a culture of health, and how, if there are particular recommendations and ideas how to increase affordability and accessibility?
Right, yeah, so that's a very important question. So when we talk about healthy foods, such as fruits and vegetables, whole grains, nuts, legumes, they are more expensive than highly processed junk foods. So this, I think, bring up an important question: how can we reshape our agriculture, the food system, to make the healthy foods more affordable, more accessible? And so one recommendation we in the report is to increase incentives, financial incentives for healthy food. For example, can reduce the price for healthy foods and increase the tax or the price for unhealthy foods. And of course, this is a difficult issue politically, because when we talk about the soda tax, it may be a non-starter for many politicians. However, I think the economical strategies, the incentives and the disincentives, can help to make the healthy choices more affordable and more accessible.
I think we have 2 more questions. One question over there.
Yes, hi, thank you for the nice summary. I was wondering, you talked a lot about carbohydrates and fats. Did the committee review at all protein, and specifically animal versus vegetable types of protein, and its relationship on health, aside from the environmental factor?
No, we didn't specifically review evidence on protein, because the current consumption of protein is relatively high, higher than the level recommended by the IOM. And of course, the overall dietary pattern recommendation will have implications on total amount of protein and type of protein. Right now, 2/3 of the protein come from in our diet come from animal products, and 1/3 from plant-based foods. So if we shift the dietary pattern to a more plant-based pattern, and then the animal protein to plant protein ratio will also shift, and this may have beneficial effects on various health outcomes in the long term.
Thank you.
Thank you for the fantastic talk. Just in terms of the presentation and the flow, I think this was a bit beyond the report, but from experience, where does, I guess, culture and religion come in terms of food shopping behaviors, food preparation? Because I guess the report has dietary recommendations for all Americans. Are those broad-based recommendations? But in your start of the talk that went into more fetal origins and early life origins, a lot of that food comes from at-home prepared meals. and every culture, I guess, because just certain changes over time. Just one from your personal experience, where do these recommendations fit in terms of, I guess, culture and religious preferences?
Yeah, so we use the socio-ecological model as our conceptual framework. And we, in this framework, we consider several contextual factors, multiple contextual factors. I think cultural, religions factors was important consideration. So when we recommend various dietary patterns, I think an important message, I think is positive message, is that you don't have to stick to one rigid dietary regimen. You can have different options and the choices in kind of designing your own healthy dietary pattern based on your health conditions and food and the cultural preferences. And the main thing is that the healthy elements, the features of the healthy dietary patterns should be there. For example, no matter what kind of cultural or religious preference you have, your diet should have high amount of fruits and vegetables, whole grains, nuts, legumes. I mean, for nuts, of course, different cultures have different, prefer different type of nuts for legumes, and of course, in different cultures, you have very different type of legumes and different cooking methods, and so on and so forth. So I think that's really the essence of the recommendation, is to have more flexibility in designing a healthy dietary pattern tailored according to your own preferences in terms of religion and culture and so on and so forth.
I know there's lots of questions about this important work, but we probably should leave time just for one more quick question. So.
Thank you very much. I promise a short question. So, Professor Hu, can you comment on the drinking of tea among the beverages? Tea. It's actually very commonly drunk among the Asian populations, and
right.
I'm sure
we didn't review evidence on tea. So the reason we reviewed evidence on coffee is because high caffeine consumption was initially considered as a food safety issue. So for tea, in the US population, it's not a major source of caffeine. Coffee, on the other hand, contribute to almost 80% of caffeine. So that's the reason we conducted systematic review on the studies on coffee or caffeine in relation to health outcomes. In the Asian population, of course, tea is the primary source of caffeine. So for those countries or populations who develop guidelines, I guess they have to review the evidence on tea and the health outcomes. Right, yeah, so we have also looked at tea consumption in relation to various health outcomes. In the US population, the type of tea and the consumption patterns are very different from those in the Asian populations. So in general, we found stronger health benefits for coffee than tea, but this doesn't necessarily mean that the health benefits of tea less in all populations. I think it may be population specific.
Okay, thank you. This is very timely for you to come here to talk about the dietary guidelines. I know in terms of the general press and social media, it's really generate a tremendous amount of discussion. And in fact, when you run into people, they'll ask about questions such as the ones that you're getting about the dietary guidelines. So certainly in terms of impact, we're already seeing a tremendous amount of impact in the media and social media, et cetera. And of course, what remains to be seen is how people will take the guidelines and whether they'll focus on certain things and focus on the major story or parts of the story. But this has been very, very helpful and very informative. And again, we're very fortunate to have you visit and give this talk, and we wanted to appreciate your taking time out of your busy schedule to do so.
Okay, thank you.
Thank you.